Bismillahirrahmanirrahim and Assalamu alaikum from Dr.Ali Husnain Sheikh. Facial nerve is the seventh cranial nerve of the 12 cranial nerves. A brief description of its anatomy. It has an intracranial segment, the portion of the nerve from the brainstem to the internal aortic canal. It is made up of two components, the motor root, the nervus intermedius. The nervus intermedius carries preganglionic parasympathetic fibers and special efferent sensory fibers. Both join at the cerebellopontine angle and the internal aortic canal to form the common facial nerve. Then it has the intratemporal segment, which is further divided into the meatal, labyrinthine, tympanic, and mastoid segments. The meatal segment is the segment of the facial nerve which travels from porus equisticus to the meatal foramen of internal aortic canal. It travels in the anterior superior portion of the internal aortic canal. The labyrinthine segment is from the fundus to the geniculate ganglion. It runs in the narrowest portion of the internal aortic canal, having a diameter of almost 0.68 mm. The greater superficial petrosal nerve comes off at this point. Then the tympanic segment, it runs from the geniculate ganglion to the second genu. It has highest incidence of dehiscence. And then the mastoid segment, which runs from the second genu to the stylomastoid foramen and gives off branches to the stapedius muscle and the cauda tympani nerve. Here is a diagram which is showing the intratemporal segment of the facial nerve. Then there is an extratemporal segment. The nerve exits through the stylomastoid foramen and gives off post-auricular nerve, which supplies the external auricular and occipitofrontalis muscle. It gives off branches to the posterior belly of digastric and stylohyoid muscle. It enters into the parotid gland and splits the gland into the superficial and deep lobe and gives off the final or peripheral branches, which are collectively known as pes and serenium, and it comprises of temporal branch, the zygomatic branch, the buccal branch, the marginal mandibular, and the cervical branch. This picture is showing the pes and serenium and its distribution over the face. Well, the facial nerve has the motor component, which supplies the muscles of facial expression, the stylohyoid muscle, the posterior belly of digastric, stapedius muscle, and buccinator muscle. It has sensory component, which carries taste from the anterior two-thirds of the tongue, and sensation to part of the tympanic membrane, the wall of the external aortic canal, the post-auricular skin, and concha. The parasympathetic segment supplies and has the secretory control to the lacrimal gland and some of the seromucinous glands of the nasal and oral cavities. The cauda tympani carries parasympathetic to the submandibular and sublingual glands. Well, if you see the cross-section of the nerve under electron microscope, you would find that it has an endoneurium, perineurium, and epineurium. Endoneurium surrounds each nerve fiber, whereas perineurium surrounds a group of nerve fibers, and epineurium surrounds the entire nerve and provides nutrition to the nerve. This picture is showing the endoneurium, the perineurium, and the epineurium. Facial nerve tests are used to assess the degree of electrical dysfunction. They can pinpoint the site of injury. They help determining the treatment and can predict recovery of functions. They are divided into two categories, the topographic or topodiagnostic tests and the electrodiagnostic tests. Bell's palsy. This condition was basically described by Sir Charles Bell. He studied facial anatomy extensively during the Battle of Waterloo and concluded that facial nerve controlled facial expression. He considered the facial nerve as the respiratory nerve of the face. If you want to define Bell's palsy, it can be defined as acute peripheral facial nerve paralysis or paresis, which is idiopathic. This means it is diagnosis of exclusion. One has to exclude the signs and features of CNS diseases and the features of ear and cerebellopontine angle diseases. There is a complete remission of facial nerve function in early if the patient is in younger age group. As the age progresses, the remission of functions of facial nerve decreases. Similarly, once a patient has developed Bell's palsy, the chances of recovery within month are higher, and after that the chances of recovery are very poor. Those who develop incomplete facial nerve paralysis at the onset of Bell's palsy have a good prognosis as compared to those who develop complete facial nerve paralysis. So what are the clinical features? It has sudden onset of facial nerve paralysis. Patient is basically unable to close his eye. On attempting to close the eye, the eyeball turns up and out. This is called Bell's phenomena. The saliva dribbles from the angle of mouth, face becomes asymmetrical, tears flow down from the eye, pain in the ear may precede or accompany the nerve paralysis. Some complain of noise intolerance because of the stapedial paralysis, or loss of taste because of involvement of chorda tympani. Paralysis may be complete or incomplete. Bell's palsy is recurrent in 3 to 10% of patients. Those who develop incomplete paralysis or have early recovery, younger patients, have good prognosis. Similarly, those who do not develop any taste disturbances, have good stapedial reflex and lacrimation, and lack of post-oral pain, these patients are lie in a category who would hopefully develop full recovery from the disease. Exact cause is not unknown. It is idiopathic condition, but there are some speculations that viral infections might cause facial nerve paralysis, particularly herpes simplex virus. In addition to that, muscular ischemia, autoimmune disorders, and hereditary factors have also been identified. It has also been associated with diabetes mellitus. 66% of patients demonstrated poor glucose intolerance. Developed those patients have diabetes. Functional recovery is poorer in diabetics. Females who are pregnant, they have 3 to 4 times higher chances of developing Bell's palsy. Third trimester has the highest risk, and there is high risk of complete paralysis at the onset of Bell's palsy in female patients, and there is low chance of complete recovery in such patients. Well, differential diagnosis of acute facial paralysis should include infections, congenital disorders, traumas, metabolic disorders, vascular injuries, neoplasms, and toxicity because of thalidomide. These should be ruled out in order to establish Bell's palsy because it is an idiopathic condition. The diagnostic tests are useful in finding the site of lesion in paralysis of lower motor neuron. The Schirmer's test, it compares lacrimation of the two sides. A strip of filter paper is hooked in the lower fornix of each eye and the amount of wetting of strip measured. Decreased lacrimation indicates lesion proximal to the genicular ganglion. The secretomotor fibers leave the genicular ganglion via greater superficial petrosal nerve. The stapedial reflex is lost in lesions above the nerve to the stapedius. It is tested by tympanometry. Taste test can be measured by a drop of salt or sugar solution placed on one side of the protruded tongue or by electrogustometry. Impairment of taste indicates lesion above the chorda tympani. Salivary flow test, it also measures the function of chorda tympani. A polyethylene tubes are passed into both bottom duct and drops of saliva counted during 1 minute period. Decreased salivation shows injury above the chorda. The electrical tests like nerve excitability test, maximal stimulation test, electroneurography, and electromyography can also be done. These tests are useful to differentiate between neuropraxia and degeneration of the nerve. They also help to predict prognosis and indicate time of surgical decompression of the nerve. Well, how would you manage a patient of felt palsy? There are some general measures. Reassure the patient. If patient has pain, then give him painkillers. Care of eye should be done. Then physiotherapy should be started. The medical management includes use of steroids. Prednisolone is the drug of choice. If patient reports within 1 week, the adult dose of prednisolone is 1 milligram per kg per day. It is divided into morning and evening doses for 5 days. Patient is seen on the 5th day. If paralysis is incomplete or is recovering, dose is tapered during the next 5 days. If paralysis remains complete, the same dose is continued for another 10 days and thereafter tapered in next 5 days. Contraindications to use steroids include pregnancy, diabetes, hypertension, peptic ulcer, pulmonary tuberculosis, and glaucoma. Steroids have been found useful to prevent incidence of synkinesis, crocodile tears, and to shorten the recovery time of facial nerve paralysis. Steroids can be combined with acyclovir for herpes zoster oticus or Bell's palsy even. Drugs like vasodilators, vitamins, mast cell inhibitors, and antihistamines have not been found useful. The surgical treatment involves the nerve decompression. It relieves pressure on the nerve fibers and thus improves the microcirculation of nerve. Vertical and tympanic segment of nerves are decompressed. Some workers have suggested total decompression, including labyrinthine segment by post-auricular and middle fossa approach. Those patients who have an electroneurography showing degeneration of more than 90% of fibers and electromyography showing no response, those patients are good candidates for facial nerve decompression. Thank you very much. If you have any question, you can ask me in our WhatsApp group or you can call me. Thank you and Allah Hafiz.